Wait, did you give me 5 minutes to do?
No, you've got 20 minutes. You're good.
Oh.
Yeah.
Okay.
So
I thought this went till 3:45.
No. Sorry? Really? Talk fast.
Sorry for saying sorry. Media presents the Purrpodcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Yola Kerpenstein, talented surgeon and social media geek.
Okay, what's going on here?
Yeah, so what's going on here? We have a microphone, so if we have a volunteer, that will be
we
fantastic.
We can hear you anyway, but if you want to...
You are live.
Yep. What's going on there?
Anybody want to volunteer? Come on.
Yeah, what's this mean? Somebody in the back's going like this. Yes. Yeah.
It's all bunched together.
Yeah,
That's really what we look at.
Yep.
But I always say to Susan, there is something else going on with this cat. Once again, always look at the whole radiograph. You know,
so
when
this
you were in
cat
vet
has another
school, they were
problem.
saying always look at it, and then they put something in. This is pretty obvious. So what is the main problem of this cat? It's not the bunched up thing. It's extremely obese.
Obese.
You know, we can deal with the foreign body. It's obesity, and you know, and then what happens in cats that you cut open that are obese?
Hepatic lipidosis.
They have hepatic lipidosis and they die. So
Okay.
focus on the important
He didn't
stuff
die.
here.
He didn't die.
So every time Susan shows me pictures, like, it's obese again, Susan. What are you doing
Yeah.
with your practice?
The first time we ever did this lecture together, I discovered this way that I have a lot of obese patients, apparently.
know.
Yeah, anyway.
But it's
so
really
yes.
bunched up. Do you have a pointer that you can
I
point
do
it out? That's
have
it
a
there. It's all
pointer.
clumped together.
Yeah.
That's always a sign. The good
Yeah.
thing about obese cats is you can see really
Yes.
clearly.
See,
in
there
the
is a
abdomen.
benefit.
So there is a benefit right there.
a benefit.
So, yes.
not
And
all
the other
bad.
good thing is that you can have at least a 2-year plan that the cat needs to visit your clinic very often
Yes.
to deal
Forever
with
weight loss
obesity.
plan.
That's
There he
exactly.
is.
Very good. So
Yeah.
yes.
Back on this one?
I've seen a lot of radiographs of lost fat cats.
Yes.
Yeah.
Mm.
They're usually not quite that localized. That's really localized. Yeah.
It's tough.
Yeah.
But fat is supposed to be everywhere
Yeah.
in the abdomen. And
I will agree with you, though, that fat can,
Yeah.
sometimes like, yeah.
Yeah.
Yeah, I'll agree with you. It's not always black and white. Yeah, but this
And,
cat
and
is
that's
really
often the
localized.
difficult discussion. When should we open it or not? So hopefully we'll get there
Yep.
a little bit when
Yep.
Dr. Sue will come
Yep.
in here
Okay.
too. It's kind of the same thing. You just have to always think about what is what. So in this cat, what was the name of the cat?
I don't remember, actually.
Oh, that really helps. So,
Blackie.
What did he
so
eat?
the head of
Blackie.
the cat
Yeah,
is
what did he eat? Yeah.
on this side, and the back of the cat is there. The stomach is right in the middle, is air-filled. That's
Yeah.
normal. So it could mean that the cat is nauseated.
Yeah.
Maybe aspirate a little bit of
we
air.
usually see them. We usually see nauseated cats
We
with air in the stomach.
see the bunching up in this area, but we also
Yeah.
see a colon that has air in it. So you always need to look where the colon is. There's some feces in the colon. So don't look at that as being abnormal because it has kind of the same pattern. But that's not the problem, obviously.
No.
It's really the problem of the bunching up the small intestine.
Yeah.
Sometimes the thread is not that long, and it's only in the beginning, so it's really difficult to see. So I understand that
Yeah.
sometimes it is very difficult in a fat cat to see.
This is a loosely bunched linear form body, but what looks again? I know it's fat,
Yeah.
but what you can you get out of the way.
Yeah.
Get
Yeah.
out of the
Yeah.
way.
Yeah, yeah.
Okay. If only this was like a real laser. Zap.
Yes.
No. Yeah. Okay. So, but
Oh,
but,
my eye.
But but notice how there's all these like little round discrete areas. That's often a giveaway to me that there's a linear foreign body in there. And then you start to see these little comma-shaped pockets of gas. Yeah, that's often at least raises my index of suspicion that there's a linear foreign body in there. And indeed there was. This cat had eaten ribbon. His name wasn't Ribbon, sadly.
No, it
Yeah,
wasn't,
but
so-
he'd eaten ribbon. And again, like you'll get a lot more bunching with these sharper, finer, linear foreign bodies, then typically you will with
Yeah, I love these. These are
Yeah,
good.
these
So
are easier.
this often is stuck in the stomach as clumped up, and then
Yeah.
it just goes out. They don't rip through the
Yeah.
of the GI wall as quickly. So.
Yeah, so some of these patients will have fairly normal abdomens on survey radiographs. And again, because you still don't know what's going on with these cats, often another type of imaging we'll use in your sort of your generically sick cat is to do an abdominal scan on these guys.
And I
So-
love that you're saying that, but give a couple of tips how you do a ultrasound on a cat that is fractious. What would you do?
I call my husband.
Oh.
Yeah. Does that count? No, no.
Give us some tips.
So I don't know about you guys. We use a lot of gabapentin in our practice. Yeah, I see a lot of heads nodding. So it's kind of our favorite drug, especially for the cats that might need something short, like an abdominal scan or a short procedure. We'll have the owner give it at home. Usually a standard dose would be 100 milligrams, and we have the owner give it 2 to 4 hours before they come into the clinic. So 2 to 4 hours seems to be the sweet spot. They don't really get overtly sedated. They just kind of don't care as much. Yeah, they're just kind of less stressed about the whole thing. If you need more restraint after that, they're then easier to work with to then get some sedation on board. So even if you're eventually going to more deeply sedate or anesthetize them, the gabapentin can be a really nice pathway. And so we often do a lot of things like echocardiograms and abdominal scans with these patients that are fearful and a little difficult to handle. We'll use gabapentin for them. So that's
And
my
can
favorite.
I make a comment about the picture?
Yes. What's wrong?
The lady so close to the cat's head, I
Yes.
think that's something that I probably would not...
She knows the cat very well. Does that count?
No.
No. Okay.
Especially when it's the owner. Please don't do this.
No, that's one of my
no,
nurses.
then it's still... I mean,
Yeah.
you need to be very careful. If the cat is painful, they
Yeah.
can lash out pretty quickly.
So you might actually see the foreign body, but ultrasonography also gives you the ability to look at intestinal wall thickness. Dr. Sue and I talked about that earlier today. So again, often we still don't know what these animals have when we're investigating them. So you can look at architecture, you can measure intestinal wall thickness, but we're also going to show you a few things that are tip-offs that you might have a foreign body in there or that you might have an intussusception, because there's some kind of distinct patterns
Yep.
that you can see with those types of things. So this is a kitty that actually has not a complete obstruction, but he's got some degree of obstruction from his foreign body. And often you'll see these dilated loops of small intestine when you're looking on your abdominal scan. And so that can be a clue, right, that downstream from that, you have an obstruction. And so
then this is always the question. And the first time she fell for it, the second time she didn't, because you said already the answer.
did,
But
yes.
is this a full obstruction
Yes.
in the cat? So what we're looking at is a piece of bowel, and I'll
Yeah.
explain why. If this full, or should this be operated immediately, or can
Right.
we wait a little bit? Because that's in obstruction always the case. If you
Yeah.
have a full obstruction, then you have to cut them open immediately. If you have a partial obstruction, you can wait until the next morning and then cut them open. So who wants to? Okay,
Full
let's do
or
the
partial?
hand thing.
Yeah.
How many people think full obstruction?
Yeah. How many think it's a full? Yeah.
Very good. Who thinks partial obstruction?
Yeah. And the rest of you have no
There's
idea. Yeah.
who does no surgery?
Come on.
Some
Professor
people are
Yola is
holding
now
back.
teaching.
Are holding back. So I always
Yeah.
look at the size of the bowel before and after and in this case it doesn't matter because it's the same. So that
Yeah.
means that there is
So you're looking at like
really-
that diameter, right? Like
Yes,
the diameter here and the
exactly.
diameter there. And if they're
Exactly.
about the same,
So if
It's-
there's a big difference, then you know there's an obstruction right there. So
Yeah.
and you can also see that on the radiograph. So if you have a small bowel that is really big and you have a small bowel that is small, you know there's a full obstruction.
Yeah.
Don't look at the colon. So the colon is always really big, and the stomach too. But if there's a small bowel that is big and a small bowel in the same animal that is small, that's a reason for me to cut them open immediately.
yeah. So that is actually the scan that goes with that patient. So you can easily see those sort of dilated areas of the small bowel that you're seeing. You can match it up there on the scan, right? So that's a clue in these patients that they may indeed have a discrete foreign body versus a linear foreign body. Okay. I thought we had one with intussusception. We'll see if it comes up later.
Yeah, we just want to talk about, I think a big change in my life as a surgeon has been the removal of foreign bodies through endoscopy.
Yep.
So we're not going to talk too much about, because we're focusing on linear foreign bodies and lymphoma, everything that starts with an L, but we're not going to talk too much about conservative therapy. And as a surgeon, I'm not very much in favor of conservative therapy. I think you put too much of a risk there. If you know there's a foreign body in there, it's a little risky. So I'm not a big...
So we can call you if it's 2 a.m.
Yeah. So anything that's in the stomach or in the proximal, you can take out with endoscopy. So send it to someone that does endoscopy or do it yourself.
Yep.
I mean, that's a big deal. And also for diagnosis, it's a wonderful tool.
Yeah, but we do sometimes have to make decisions. So there is three big buckets, right? Do we do conservative management? Sometimes that's as much dictated by the owner's circumstances as anything else. So, but we do need to know kind of which patients are going to have likely a better versus worse outcome, or do we go in endoscopically? So can you reach it with the endoscope? Is it the right type of foreign body, or we do surgery on these guys? So we wanted to show you this study. So it's an old study, but it's a good one. And it's a study that looked at just cats with linear foreign bodies. These were 24 cats, came in with diagnosed with linear foreign bodies. And 19 of them, they initially, and remember this is in the 80s, so not so much endoscopy going on then. So they decided to, and at least initially, manage the majority of these cats conservatively. Of that 19, 10 of them still ended up in surgery. It's like linear foreign bodies are one of the categories you are likely going to end up in surgery.
And 9 probably were misdiagnosed, I would.
Oh, and the others were misdiagnosed, yeah. Now, the good news is they all survived.
I would never wait with a linear foreign body. Once again, I understand the study, and it might be cats that survive, but if you have a more than 50% chance that you have to go to surgery anyway, why not do it immediately? So
so I think that's a good thing to keep in the top of your mind, that probably surgery is the better route to go with linear foreign bodies. And if it's an owner who, for whatever reason, isn't able or isn't at that place right now, you need to let them know that most of these guys are going to end up needing surgery. Okay, so this study also looked at which cats might be, because they did choose to treat some conservatively. So they do have a little bit of data on, if you're in that position, because the owner, again, it's the owner's circumstances, says, hey, doc, is it possible my cat could get by with just conservative management? So of their cases that survived with conservative management, they were the ones that were not sick very long, and they didn't have very dramatic clinical signs. So they were brought in fairly quickly. They weren't seriously ill. They didn't have abdominal pain. You couldn't feel intestinal bunching, right? A lot of these cats that were managed conservatively didn't even have radiographs. This is all physical exam based. So no fever. They didn't have anything abnormal on abdominal palpation. They did have some minimal lab work done, and there was no serious metabolic derangements going on there. And they also checked under the tongue. And what they did in this case series is that they saw a foreign body anchored under the tongue. They cut the foreign body. They cut the linear foreign body. Because, again, they're going to go for conservative management for whatever reason. So if they couldn't do that, that was a bad sign, right? If there wasn't anything to cut loose in this minimally ill patient.
That kind of makes sense. Huh?
Yeah. So not that we're advocating this, but, we all get in that position where you have an owner that, just can't afford, for whatever reason, to take their cat to surgery. At least you've got some criteria that's going to give them some idea of, is this likely to work or not?
Yeah,
right?
So the theory is here that with the linear foreign bodies, it always gets stuck somewhere.
Yeah.
So if it's stuck under the tongue and you relieve that obstruction, it's possible that it will move through the... If it's not stuck under the tongue, it means it's stuck somewhere else.
Yeah.
So most of the time that's at the pylorus.
Yeah.
So, not
and
doing
there's not
surgery
much you can do about that.
is then
except
not
surgery.
Yeah, exactly.
Yeah. So that's kind of the rules that I go by when I'm talking to owners about, who could we possibly get away, even though it's not my first choice with conservative management. Oh, so I'm going to let you talk about endoscopy, Yola, because this is Yola's thing.
I think we talked about this already a lot. The thing that I would like to point out is when we talk with some people, they say, endoscopy is really good for dogs, but cats are much too small for this. And I want to just debunk that. Cats are awesome to do endoscopy on. Not only this kind of endoscopy, but I did a lot of laparoscopic surgery and thoracoscopic surgery in cats, and they are awesome. They're very inflatable. Which I love. So you have much more space. So don't listen to anybody that says it's not possible.
Inflatable before, really.
So
no.
It's inflatable what counts.
Okay, I like that.
You know what is also really good to inflate on?
What?
Is ferrets. They're also very inflatable. Love them. So don't have anybody tell you that you cannot do endoscopy in cats.
I think that's going to be like the tagline when we do social media for this. Cats are inflatable.
Yeah, they are.
That'll work.
Hey everyone, it's Tom Bond with the North American veterinary community. Does it get any better than listening to a podcast with Drs. Yola Kerpenstein and Dr. Susan Little, two of the best in the industry? And we are so proud as NAVC to be sponsoring this podcast and hoping that you're going to get ready to join us at VMX 2020 coming to Orlando in January of 2020. Hope to see you there, and we'll have more conversations about feline foreign objects, other types of foreign objects like the corn cob that my Old English sheepdog swallowed. Make sure you join us. Thanks.
Let's look at a couple of pictures. Oh,
Yeah.
so you're going to...
Dr. Sue, what's wrong with this cat?
Yeah.
Fat.
Yay! Yes. All right.
Okay, I think our lighting is going to make it a little bit hard to see.
Can we turn off the light somewhere?
I don't
There's a
know.
who wants to push the like button?
Yeah, just like
For
push a light
Dr.
and see what
Sue.
happens.
Because we want to put Dr.
Yeah.
Sue on the
Yeah.
spot right here.
I'm dangerous
Is
around
there
light
any
panels.
light-
Sometimes,
Wrong way.
Oh, the other way. Yay! Oh.
sometimes I shut down the whole building. So.
Yeah.
That is a small cell lymphoma.
Oh, I like that. Good skills.
Small
Thank you.
cell
Mad
lymphoma.
skills.
Okay.
Yeah,
Yeah, it's
and-
not very difficult.
Oh, there's a needle in there.
Oh,
Yay.
excellent. So let's talk about needles
Yeah.
a little
I'm in my
bit.
intro.
So,
Yeah.
because
I
it's
know.
always, for me, it's always a
Yeah.
discussion, should I take that needle out, yes or
I
no?
know.
So I know that there is some research done, as you can see here. And so it really depends where the needle gets stuck. So when the needle gets stuck in the proximal part of the digestive, most of the time there's very violent signs. And so those often start migrating because like that, and then
Yola
it perforates through.
Retching cat.
Yes, but and a lot of them you can remove if they're in the stomach still. I mean, you can just remove them by endoscopy. And how would you do that?
Inflate.
You inflate them and then? Yes, and then
Yeah.
you pick up the little string and very gently pull the needle back out.
Yep.
Don't pick up the point
Don't
and
pick up
try
the
to
needle,
rip
yep.
them out that way. You can if you're a really good endoscopist, but it's really easy if you see a little string and there's a needle on it. That's how it came in. That's how
How
it
it
can
goes out.
come out. So it is relatively easy to do.
Yep.
But if the needle is further away, then obviously you cannot do that anymore. But like I said, I think that if you look at endoscopy, most of them are
93%,
successful.
yeah.
So okay.
Yep.
So
Very good. Oh,
what
I
about
like
this one? Ooh.
There's a needle.
Yes, thank you, Dr. Sue. There's also
just
a lot
cancer.
of gas. Yes.
Yeah, a needle and lymphoma.
Yes.
Exactly.
Yeah, yeah,
Yes.
yeah,
Start chemo.
yeah. Which
So-
end is pointing which?
Yeah, that's always the question, huh? So
Which end is pointing which
So
way?
I have a theory here. I think if the pointy end is pointed to the front, it has a higher chance of passing through than when the pointy end is pointed to the back of the GI tract. Why is that? Because the GI tract is kind of contracting on it, and it's moving the needle that way. So if you see the next picture,
Whoops, sorry.
it's right
Ah,
there. So
yeah.
this owner had no
See?
money,
Yeah.
and so we just waited and saw if. And it's amazing what can
Yeah.
go
See?
through the GI tract.
Sharp end,
So
blunt end.
That's crazy.
normally,
Right? And
I
then look.
tell the owner
isn't it?
not to do
Yeah.
this. So
Yeah.
I
Yeah, we don't
normally say,
recommend
let's
this,
take it
but-
out. So
Yeah.
how do we take these out? It's very simple. I feel where the needle is, and then I grab the needle and push it through the
Intestinal wall.
intestinal wall, and then pull it out.
Yeah. So you don't make an
Very
incision. You
gently.
push the needle through the intestinal wall. Yeah. Right.
You pull very gently.
Yeah.
If you feel resistance, there might be a thread attached to it. So then you don't keep on pulling. Then you have to be. But most of them, if it's just a needle or a short thread, you just pull them out. And what do you do with the hole? Just clean it up a little bit, drop it back in, and the cat will be fine.
Yep.
Or put a suture over it, put a little omentum on it. That's it. Don't make a big incision in the GI tract, start suturing and that sort of thing. It's not necessary.
Yep.
However, if you can't find the needle, there's two things that you have done wrong. One is you haven't done the 3 radiographs, so you cannot find exactly where it is. The other thing that, we're talking feline. The other thing is that it might be feline lymphoma. No, I'm just kidding.
They ate the needle because they had lymphoma.
Yeah.
So for
Good
me,
segue.
it is. I'm a relatively lazy surgeon, And so with these needles, I'm not that worried about it. So a little hole in the GI tract doesn't mean that the cat's going to die from severe peritonitis.
Yep.
If you don't feel comfortable with it, perfect. Then you just make a bigger hole. That's fine with me too. But a lot of these needles you can just pull out.
Yep. So we thought it'd be really nice to have Dr. Sue come.
Wait, did you give me 5 minutes to do?
No, you've got 20 minutes. You're good.
Oh.
Yeah.
Okay.
So
I thought this went till 3:45.
No. Sorry? Really? Talk fast. No. So the reason that we did is because, of course, when these cats start off, you don't really know what they have when they come in, and they may end up having something like IBD or lymphoma. So go, doctor.
Okay,
Sue.
and so you'll see that some of this stuff got messed up. I used Keynote, and we literally switched some stuff.
At lunchtime.
Yeah, you weren't supposed to fix that.
I did. I know.
Oh, it's
It
going to
Okay.
be messed up.
Shh, I only have 5 minutes.
Oh.
Stop. Okay. No, so the goal was we're predominantly going to just compare and contrast small cell lymphoma with IBD, which is what we were doing in our talk. There are a few things in here at contrast with high grade as well. But lymphoma is one of the most common cat cancers that we see, 30% of all cancers. As you guys know, this is not something, even if it's causing an obstruction and you have to cut it out and do a resection and anastomosis, you need chemotherapy, right? This is a systemic disease. It's not curable with surgery. I'm sorry, Yola.
No, but there's a big question, though, because one of the
Yes,
questions I
whether you should-
always get is, should I cut it out or not, or just leave it in and then treat it with chemo?
So my rule of thumb is, in general, if it's not causing a full obstruction, we will try chemotherapy. Every once in a while, you have that case that for the high-grade lymphomas, where it's more of a solitary GI mass, where you'll give chemotherapy, and because the lymphoma was infiltrating all of the layers, you can have a perforation. I've only had about 3 or 4 of those in my entire career. But in general, if it's a partial obstruction, I will not take them to surgery. There is a newer study looking at that that did have improved survival time. So I think, as I always say, you can put 4 oncologists or surgeons in the room and probably get 7 opinions about whether or not. But in general, it's not a surgical disease exclusively.
And when you do an exploratory and you suspect it is one, so you see a solitary nodule, you don't know exactly what it is, it's a cat, so pretty good chance that it is lymphoma. Should you then, but there's no obstruction, should you just close them up and put them on chemo, or should you remove it at that point?
I would remove it if I was there.
Okay.
If you're in
Great.
there,
If
Thank
you're
you.
in there, I would remove it.
Yeah.
What if you have an aspirator, you don't know if it's an adenocarcinoma, you're going to be really upset, right, that you didn't remove it, because that is a surgical disease.
Cool.
Yeah.
Cats tolerate chemo much better than dogs, and most owners are really surprised with that. They just think they're small, little, fragile creatures, and they're not going to be able to handle chemo. So I make the owners guess: dogs, cat, and people. Who do you think tolerate chemo the best? They're cats, really? And I was shocked during my internship and residency to see that as well. One of the frustrating things about cats, we talk about their clinical signs are frustrating, is that their response rates to the lymphoma, especially high-grade lymphoma, is less predictable. There's a subset of kitties that don't respond, and then you have a subset of kitties that go into complete remission and will be long-term survivors. But it's very hard before you start treatment to be able to predict which of they're going to be. These slides are all messed
Well,
up.
I'll tell you why in a minute.
Okay. The prognosis, again, even amongst gastrointestinal lymphoma, small cell, which is low grade, and high grade, which is the large cell, is going to be quite variable. So just focusing a little bit more on the low grade small cell, this just fits exactly what Susan was talking about. Weight loss, vomiting, diarrhea, and anorexia.
Okay, check.
Great.
Yeah.
Great. And then, this tends to be a chronic disease. These are cats that have these symptoms usually for about 6 months. And again, we talked about, most owners still think vomiting somewhat normal. They just eat too fast. We make a lot of excuses. They just eat the plants. It's just hairballs. So again, these cats have often been sick for a while. Sometimes they have an abnormal palpation. Sometimes ropey intestines when you're doing your exam. Sometimes it's normal. It's sort of like we were talking about before. The absence of an abnormal exam doesn't change it. My own cat, which had IBD, his symptom was weight loss, as I mentioned, vomiting, normal blood work, normal cobalamin, normal ultrasound. Took him to laparoscopy and still had IBD. So again, they can have normal diagnostics and normal exams. So there's this new terminology that's creeped into the literature where type 1 EATL is your high-grade lymphomas. We're not going to spend as much time because of time, but those tend to be quicker, sicker. Those are easier to diagnose. Those are the ones that you can feel a mass. It might be a lymph node. It might be a mass in the intestinal tract. You see it on ultrasound. You're able to do an ultrasound-guided aspirate, and you usually confirm that quite easily with cytology. Large cell, high-grade lymphoma based on your cytology. In general, unless it's, an obstruction, we don't typically take those to surgery. The frustrating ones are these low-grade kitties because everything is really similar. Their symptoms, their exam, their ultrasound. Cytology is usually non-diagnostic. They might have abnormal thickened bowel on ultrasound, but they might not, but you still need surgery, and you need some sort of biopsies, whether it's endoscopy, full surgery, laparoscopy like we did. So those are the really frustrating ones where you're like, I'm not sure if it's IBD, I'm not sure if it's low-grade lymphoma, and those are the frustrating ones. So cytology is rarely useful. You'll, again, get very differences of opinion. Remember, endoscopy is only going to reach stomach and upper small intestine. So if it's in the ileum, you're probably going to miss it. And those are the cats that we want to do surgery to get our biopsies or laparoscopy if we can. And then they'll diagnose whether it's lymphoma or IBD. The other thing that's really important is IBD, we know that one of the causes for low-grade lymphoma is chronic inflammation. There are cats that have IBD that will progress to the lymphoma, and there are cats that have lymphoma that have concurrent IBD. Yep. So when we're thinking about treating a cat with low-grade lymphoma, I'm going to do everything that she wants me to do for IBD as well. Probiotics, diet changes, because again, lots of these kitties, maybe they got missed as IBD, but again, they typically have both diseases concurrently at the same time.
The only thing I want to add here is if you do biopsies, and we talked with Dr. Stan Marks about it in one of our podcasts, is do them in every part of the GI tract. Yeah. So don't forget the ileum, do one in the duodenum, do two in the duodenum, one in duodenum, two in the jejunum. The only thing that wouldn't biopsy is the colon.
And then just remember that the gastrointestinal side effects of chemotherapy are vomiting, diarrhea, decreased appetite. Right. What did they present with? Those symptoms. So these are kitties that we want to be, in general, remember, cats tolerate chemo very well, better than dogs, but they're already displaying the symptoms that chemotherapy could exacerbate. So be very proactive. Everybody in my practice, they automatically go home with Serenia, metronidazole in their goodie bag, some probiotic, and I'm also loving Mirataz, the topical ear product, and we can use Entice off-label, and if they're having chronic diarrhea, I like a product called RX Clay from RX Vitamins. And again, everybody goes home with this and an instruction sheet, and again, educating those clients about nausea. They know what vomiting looks like. They do not know how to identify nausea, and they need to be proactive with those medications. Then finally, how do I treat low-grade lymphoma? So the high-grade lymphomas, we're going to use a CHOP or a COP or oral lomustine. We're going to use the bigger gun chemo, right? But for those low-grade lymphomas, the slowly developing ones, we don't need the aggressive chemotherapy protocols. So those are the kitties. Basically, I like prednisolone. I'm a prednisolone, not prednisone girl. Yep. We want the active form, right? It's estimated 50% of kitties cannot activate pred into prednisolone. Can you look at the cat and know? No. So and pred works in plenty of cats, but again, I'm in the prednisolone camp, and then I use oral chlorambucil. There's a couple of different dosing. These pulse dosing, you see, you're giving this high dose every 2 weeks, or this dose every 3 weeks for 4 days. So for the podcast, 20 mg per meter squared every 2 weeks, or 15 mg per meter squared every 4 days for 3 weeks. I really like the chronic low dosing, which is similar to what Susan does for IBD, which they're usually getting it every 2 to 3, and then every 3 days as maintenance. A small cat's going to start as every 3 days and then go to every 4 days. So, and I find that the survival times, these kitties often lived, 18 to 24 months. They do quite well, very different than our high-grade lymphomas. And again, they typically don't need aggressive chemotherapy. But they can progress. Like my kitty, they will at some point become non-responsive. And often these kitties can progress to high-grade lymphoma and need bigger gun chemo. I'll do their pred at 1 to 2 mg per kg per day. And then I decrease them. I try to get it on the lowest tolerable dose. I was talking about earlier, I did make a cat a diabetic early in my career, so I tried to get more cats off prednisolone as a result. And I found as I tapered them off pred, their symptoms recurred. So I do end up keeping most of my cats on, usually about 2.5 every other day. And then when they relapse, you'll just go back to the bigger gun chemotherapy. I think I'm done.
Yeah.
Whoa, that was...
And then don't forget food, don't forget IBD, don't forget probiotics, and don't forget B12.
Don't forget B12.
All right, so thank you so much.
Just go ahead to your Facebook group.
If
Just
anybody
go ahead
has
to
some
Facebook.
questions and want to
Just keep
stay,
going
we
fast.
will stay here for the next 10 minutes too. If you want to
That's
run
fine.
out,
Leave that
that's
up
fine too. We'll
before
just
you're leaving.
let people move around a little bit.
Yeah,
And
just 1 second.
But if you have some questions,
It'll-
then we'll
it'll
definitely
be-
we'll
All
stay.
right, there, leave it on that.
Guys,
Okay.
this is a closed Facebook group. We'd love for you to join. About 3,000 vets. If you have questions, we put them there. You guys in there?
Well, I will be today.
Yes,
you-
me too. I think I am.
I think you are.
I
Come
think
visit.
I am, of course.
All right. Thanks, guys.
Yes.
The opinions of this podcast are those by Dr. Susan Little and Dr. Yola Kerpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @Purrpodcast. Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August's Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatVetSusan. Dr. Yola Kerpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Yola works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX.